stay here because you're going to join the Q&A session, and I will call back Susan for FutureGEN, Maria for GenPath, and Karine for GenderARP. So please join us, and I'll take my phone in case we have questions coming in online. Whichever, I mean, you can, I think there are 3 mics, so are we missing a chair? Take this one, otherwise, or that one, maybe this. Yeah, sure, okay. We can take turns, otherwise. So, I don't see any question coming in online at this stage, but do we have questions from the room on any of the projects that have just been presented? I think it's a lot of information to process. So yes, of course, if you have a question,
I have
absolutely.
a question. Is this on?
Yes, it is.
Okay, for you, Maria. I was very interested in your comment that childhood experiences might lead to loneliness later. And I think about the ACE studies, the Adverse Childhood Experiences studies. And do can you reflect on those studies? Do you know what I'm talking about, those studies? And
I don't know the studies. I don't know the details of the study. I've heard about it, but yeah.
So the ACE studies show that the more social disadvantages children have, the shorter will be their lifespan, and the poorer will be their health. And these were done in the U.S., so they're somewhat specific to the U.S. And social disadvantages include parents who die, parents who divorce, exposure to abuse, that sort of thing. It just struck me that, you are finding the same thing with a different but related outcome.
Thank you. That's a very interesting question. I know I did another study similar to what you described on cognitive functioning in later life, and then you see also that those children from the most disadvantaged families, they have the lowest scores on memory functioning and all these things. So I think it's a very, very consistent finding that it starts very early in life. And then disadvantage, for the cognitive aging study, for example, we defined disadvantages as living in a house with many people, sharing your bedroom, or not having books in the house, all these things, or going to bed with hunger and these things. I think when it comes to loneliness, that is a feeling very much related to not having what you like to have. And there I think socio-economic status of the family where you're born in plays a role. I mean, we found it, but yeah, I think it's very interesting to realize also for interventions that start early in life is very, very important. And I think the other, what I still find intriguing is that even a little difference in the beginning becomes a huge difference in the end. So this fan spread movement, we call it sometimes, that differences become larger and larger the further we get in the age, in the biological age. Was that an answer?
Yeah, yes.
Sort of.
Yeah, and your last comment was the one that really strikes me, that these disadvantages persist and smolder and fester and get worse and worse.
Yeah.
Question in the room? Yes, we have a question at the very back there. Do we have a mic for the person in the room? Yeah, thank you.
Who's the person?
Yes. Thanks, Chloe. Hello. Very interesting presentations from all the projects. So I thank everyone, including the guests online that have joined. I've got a question for the FutureGEN. And I think the GenPath, I'm hoping I've got all the names right as acronyms. On the FutureGEN, very intrigued by the questions around aging. I'm Dr. Karen Salt, by the way. I'll be speaking tomorrow. But I'm very intrigued by the aging conversation and wanted to know, had the team thought about aging of researchers? and life cycle of researchers, and mainly because a lot of what was being presented, you could probably look around research and innovation and see quite a lot of that played out in that population. Just a query. And then for the GenPath team, I'm really intrigued about the exclusion from social relations, and I would expect the teams have covered this, but at least in the presentation, which I know you were pressed for time on, migration or movement to the from the countryside to various locations wasn't mentioned at all around some of the cultural understanding, and we know these are significant issues in Spain and Italy as well as in Japan. So I just thought I would ask how those featured in any way.
Right, Susan.
Okay. So as a group, we did not consider aging and researchers. I did, because I was the oldest of the group. But that's a very personal reflection. One aspect where this may have entered into our research was in the qualitative study. We had 3 fairly young interviewers interviewing those over age 65, and all the interviewers were female as well. So almost certainly that will have affected the responses. All we can say is it probably reflected those, influenced those responses in a consistent manner, but we can't say how, what the effect was.
Maria, would you like to add something since you were also included in the question?
Yes.
It's on, yeah.
Is it on? Okay. Is it really on?
No,
No.
it should be.
Thank you.
Yes.
This one is. Thank you for the migration question. Yes, definitely. There is an impact. Simply thinking when it comes to communication. If you cannot communicate, then it's very hard to connect to other people, and then loneliness is around the corner, I would say. In GenPath, we did 30 qualitative interviews in each of the countries involved. So in the end, we had 180 qualitative interviews, and several of the interviewees, the people who we interviewed, were actually from another country. And they mentioned, actually, I think all of them mentioned the hard time they had when they moved to another country. Not only language, that's an important one, but also culture and not understanding what to do to be appreciated by the culture. And I'm an immigrant myself, so I totally understand how that works. So you go to another country and then you try to do what is appreciated, but then if you don't know what is appreciated, then you sometimes have a hard time. So so from my own experience, from the qualitative interviews and from quantitative research, we know that not being able to communicate is a very large risk factor for loneliness. So thank you.
Thank you. Now, I have we have received a question online, but I'm going to tag it along to something that I wanted to ask you as well, and that's really for all 4 of you. What surprised you most when you applied a gender or intersectional lens to your research? And in Susan's case, and that's the question we got online, what was the definition of intersectionality that you used in FutureGEN? So I give you time to think about that. Maybe I'll start with Karine on this one. Somebody has to start.
Yes. So what surprised the most? It's maybe the importance of stigmatization within services for when we apply, and how it's this stigmatization experience is more accentuated when we have an accumulation of the minority groups, of the minority groups. So in fact, the gender, for example, in the model that I presented just before, I didn't think that there was so much stigmatization during the life course, during their use of services. So that's one thing that happened, that we know that there was stigmatization, but for example, for non-binary and trans people who needs to have some specific services, there was a really specific issues important that is also discussed with our partner. So the concerns about the organization, like in substance abuse treatment, we offer also some facilities where they have to have many decisions. How do we try to have the security safe space aspect? Example, for women who feel that it's difficult to have a mixed gender, for example, services, but also with people who do not identify like with this binary kind of so not as a woman, not as a man, or the trans people who have their expression of gender is not in coherent. It's difficult. For example, a masculine person who identify as a woman. So there's a lot of concerns of our partners. So how do we maintain inclusion, safe spaces, and respecting the needs of every individual? Some who were, for example, assaulted by men for many times, they can feel difficult to be in a group with somebody who identify as a woman with the masculine aspect. We know that these kind of things we will see some, but that to see that our partner are really concerned about and wants to have some dialogue surrounding these issues, it was a surprise in a way, because I think the reflection in Canada, I speak more maybe in Canada, it's really an issue that it's now it's a shared concern for many of our partners, more than we thought maybe. So that's one part of the answer. And for the intersection, we did in many ways, but we did also with age. We talk about aging. We also look at for example, youth, adult in the youth, for example, young adults. We try to look at the empowerment perspective also. We look, for example, at musical aspect in the music in the community, how the strengths and the specific strength of the person who use substance, and to see what is important for them from an empowerment perspective and community perspective is really various across the different groups. So that's another aspect, to be short, that was interesting. So we didn't think about music before, but it's a doctoral student, for example, who bring that. And the punk woman, for example, who are homeless, was one of the subgroup who really talk about a different way. So how can they be considered in their strength, and then their also their strength in the social aspect of their strengths, going further the traditional way in addiction research and services, to say working with the community is working with the family and the couple. So we have also some discussion about the aging and how it influences also their vulnerabilities, but also capacities.
Thank you. I'll ask you to keep your answers a little shorter, so that everybody can answer all the questions we have. So Bilkis,
yes,
the most surprising...
So I do have a quick point to respond to what you asked as a question earlier, but did you have a specific question for us? Because about gender and intersectionality, when you think about FGMC, in essence, we were between women, working for women, listening to women's voices, and across the countries. And even some of the biases that were highlighted by my colleagues and in our own project, mostly physicians, social workers, midwives, anthropologists were women. And yet, at the end of the very day, when you reflect on that practice, one is thinking, is it being done for men? And performed by women, most, if not at all times. And how do we involve men, and how do we make men speak out? So I'm going to have the mic to my colleague here who has a quick answer to that. Putting you on the spot, Sarah.
Thank you very much. I'm not quite sure. I had absolutely no idea where Bilkis was going with the men. I think for me, one of the most surprising things was how varied perceptions of the body are of women in different places. So you can't assume, there's often a tendency to victimize or to say, you know, they have undergone a mutilation or they're victims in different places, but many women don't see themselves as victims, as when kind of discourses in different places are negative, they affect women far more than, in some cases, than the actual cutting that they've undergone. You have women who've undergone the cutting and who are sexually satisfied, who don't have any particular problems, and other women for whom it was very traumatic. So I think it's very important not to judge or put them into the victim category, but to kind of just listen to their needs, their particular needs, depending whether it's psychological needs or medical attention, and and I think men, I mean, most of the women, as Bilki said, were cis women. So the question of intersex, there wasn't really, we didn't come across, I think in none of the countries, we didn't come across any women who didn't identify as women. Yes, so a few years ago we did this project called Men Speak Out, where we were working on men's perceptions on female genital cutting in different countries in the UK, in the Netherlands, and in Belgium, and that was incredibly interesting. But I can't really go into detail on that. But men are very important to include in the process. Yeah.
So in that case, it would be more of a cultural lens, really, rather than gender or intersectional, really, that should be applied to your research. Maria, what about you on that same question of what did you find surprising in your research?
I've been thinking very, very hard all the time that you were talking.
If anything,
oh my
I
God.
mean, maybe there wasn't anything.
Maybe I can pass the mic to my neighbor.
Please do.
No, just some few words.
Yes, you've got to come closer, because otherwise you're not on camera.
I think that a thing that was very... No, that's okay, thank you. That was very important in our project, and that echoes to what you just said, was strengths of the group, and the fact that at the beginning, as Karin said, we have this lens of victims, this lens of vulnerability. And with the feminist groups that I work with in Marseille, in the south of France, I collected a lot of testimonies that were focused on vulnerability and stigmatization. But by putting in words the individual suffering, it became after a strength for all of them, and the collective stories were a way to empower themselves. And that was something that was very important for the project, and that's why we decided after with Karin to use this narco-feminist approach that is used by feminist women, by women who define themselves as feminist, and we also applied this approach to women who use drugs, who are probably one of the groups that is very, very stigmatized because drug use is an illegal practice in France, in Quebec, and also in Belgium.
Susan, then I'm going to come back to you. You had a double question, so the definition of intersectionality in FutureGEN, and of course the elements that you found most surprising when applying the gender and intersection lens.
So I'm a bit like Maria, that I had to think carefully about the most surprising. I think what surprised me most is how unchanging things are. So if we had predicted beforehand what the outcomes would be, that's pretty much what we found, that gender roles persist, gender inequities persist across place and across time, and really just go on and on. The definition of intersectionality, so this could be a 3-hour discussion, and I won't go anywhere near that. What we used was the overlap of sex and social sex and social locations, such as socioeconomic status, race, although we didn't have race data anywhere to use, but that overlap. And we didn't go down the path of overlapping oppressions. We just did overlapping social circumstances with sex.
Thank you. So, Maria, do you have anything to add to this now? Now that you've had a little more time to think about it?
Now I dare to. Well, I still find it hard to say what is the most surprising, but maybe I can say what I still find the most intriguing question in whole gender studies is well, I started with that, and I like to repeat because I still find it very, very fascinating how it is possible that women are so universally disadvantaged. Why? And it's I think we only found in our project, at least, we only scratched the surface, I think, there, and we're still not there where we want to be, because, well, we found some effects, but I think altogether, the whole idea that it's reproducing all the time, I think I agree with you, Susan, that there's actually very little change, or we can almost predict what the outcome will be, and then we, surprised or not, we find it then also. So I think we're not there with understanding where the gender differences come from, and I feel that we have a lot of there's a lot of research needed, but also maybe even philosophical thinking and humanist and environmentalist, and I think we really need to work together to come closer to the real issue, I think.
Mm-hmm. Bilkis, you want to add something?
I just wanted to add a conversation we had earlier with the Canadian researchers, and we'll probably have some really interesting discussions tomorrow. But I think it also refers to the definition that we give to concepts, variables, determinants. You know, it all depends on the lens that you adopt. And over the years, especially when we look at the various countries involved, and also listening to other presentations, especially from the Paris seminar, and we discussed that this morning, is how gender is defined differently, either in terms of the social locations, as Susan was mentioning in her work, or in terms of sexual identity and sexual divide and sexual orientation. You know, and they do intersect, but it's not always defined in a way that, you know, you could capture adequately. So gender studies are very complex, I think, and that really, you know, some become just women's studies, and then we have men's studies, and you know, our Institute of Gender and Health, and I'm sure our new scientific director will talk about that. We did have a stream for men's health specifically, because then we were, you know, losing some of the men don't access healthcare services either, you know, at the time that they need. So anyway, I think definition was one of the element of importance that we need to focus on. Thank you.
Do we have another? Yes, we have two more questions in the room. So I'll ask the lady with the pink sweater first, and then we'll come down to Jose.
Now, I'm Sophie Alexander, and I'm part of the RHCforFGC. And it may be anecdotal, and it may be to the point. We are very few men working together on this topic, but one of them is an American called Brian Earp, and he is the one who has made us think about, is female genital mutilation the only problem, or is male circumcision also a question? Now that question comes from the men, and none of the female researchers had it.
Mm-hmm.
Do you want to take the second question?
Yes,
or, yeah.
yes.
Thank you so much for this very interesting conversation. I just had one question for Susan and Maria. Well, it's a shared question, because my own project is also about aging and masculinities, and men specifically. And I was very much intrigued by your results, because actually we got just the opposite. Basically, the idea that your results were you said that they were quite predictable in a way, right? That what you were expecting was what you found. Actually, in our case, I have to say, we found very much what we did not expect to find, which is, for example...
Sorry, I think we've lost the mic, actually.
This one.
Is it working? It's
Yeah, now
working.
it is, yeah.
Have to
Okay.
speak close.
Okay.
Yeah.
Sorry. So we found basically what we did not expect to find in many ways. And for example, in the case of social exclusion, I think it's also a matter of how you define exactly social exclusion. Because if you define that in terms of poverty, for example, it's clear that women are, as you said, disproportionately disadvantaged, right, compared to men. But if we talk about, for example, social relations or social networks and connections, what we did find, at least in our case, and I'm talking about Spain now, which is a very specific context, is that older men, for example, were much more socially excluded than women, that they had problems relating to other people, a much smaller network of social connections, and they were much more lonely, actually, in relation to, compared to women. So I think it's striking, like, I don't know, I think we have to be very careful also with the definitions, right? What we mean by social exclusion, how to define that exactly. And also in connection to the older men, I think it's very important to as you were mentioning, the issue of sexuality and sexual diversity, because in the case of, for example, older LGBTQ communities in Spain, vulnerability, sorry, and social exclusion is even much more clear, so just a comment, but very interesting findings. Thanks.
Thank you. So let's start maybe with the circumcision issue. Bilkis, I don't know if you want to take that one maybe, or your yes, exactly, because okay, can you take one of the mics? Yes,
sure. Yeah.
What about the point that was made, and that came from one of the few male researchers?
So Dr. Alexander is actually in our team, and so is Dr. Brian Earp. And I don't think I really have any answers. I think she was giving a comment that was kind of a comment question that I can revert back to Dr. Alexander in responding to that. But indeed, Brian was actually at the Paris workshop, and he's a philosopher in terms, and I'll give you the mic, Sarah, in just a minute. But I think those questions are very important because it also leads to the cosmetic surgery that are done or requested by women purposefully. Of course, it's, once they have consented to that, so, you cannot compare, but you can think of those various surgeries that are being done and who is doing them and for what reason. So, of course, the male circumcision, there is a wealth of evidence that's written in terms of trauma as well, and also done prior to the age of consent. So age of consent, sort of comes in the mix, and certainly requires, a bit more research, as much as, and it all depends on the reasons why it's being done. So, there's a lot to learn on that, but I won't expand more. I'll give it to Sarah and to Birgitta. Birgitta, go ahead.
Yeah. Actually, before Brian Earp was born, there has been a long discussion about this male and female, but it has been stopped all the time because the freedom of religion and the religious aspect have cut the discussion down. Several times, pediatrician has tried to raise the issue of boys, that boys are so unprotected and the integrity. And actually, in Europe, we see now with the laws that girls are so much protected against this body integrity compared to boys. But the issue of religion is there. So. And as it both Muslims and Jewish who practice male circumcisions, and as the United Nations have actually legalized the argument, the religious argument is higher than the gender argument in the United Nations. Mm-hmm. So that's...
Sarah?
I think one fascinating point of comparison that Brian Earp has brought up is comparing minor forms of female genital mutilation according to the WHO classification, like just just incising or even piercing, genital piercings, which pricking exactly, which 20 years later are completely invisible for a surgeon cannot, or not even a surgeon, but many gynecologists and health professionals cannot even identify a minor form of female genital mutilation, comparing this to things like intersex surgery. So even an adult woman, according to the current zero tolerance policy, is not allowed to undergo a female genital mutilation if it's according to the if it's for cultural reasons, or within the like the Dowdy Bora, which Birgitta Essner has worked a lot on. She's got some fascinating insights. This is totally illegal. There's zero tolerance. Whereas compared to that, boys are circumcised. There's no consent. Intersex surgeries are being performed on children before the age, they are not able to consent before they have decided if they want to, what they want to be, or how they, in terms of sexual identity. And that's the issue that Brian Earp has really brought up, and that's absolutely fascinating. And I think we still have a long way to go before raising awareness even about this issue, comparing female genital mutilation to other forms of body modifications that are done without consent.
Also realize the heterogeneity make WHO to realize the heterogeneity in the practice of female genital cutting, from no anatomy, no flesh taken away to much more tissue taken away. So there's
okay. So that we've clearly got a huge range of questions stemming from your study. And much more work to be done. To pick up on Jose's point, and I'll come back to you, Susan, on that one. Big differences in finding out or in the results of the research. Could that be maybe cultural or?
So I actually think that we found the same thing, and I may have not been clear when I presented, but think of our qualitative research where we found that both men and women thought that women aged well better, and that women considered social connection as the key to aging well, and men considered resources as the key to aging well. So if I sort of unpack that, it says to me that women have better social connectedness, I guess is the right word, and that's exactly what you found. Do you want to speak to that too, Marie?
No, yeah, I agree. I think when it comes to, for example, social isolation or loneliness, women live more often alone because they live longer, and then they widow, or they are bereaved. I think that's more often. So therefore, they live more often alone. So in that sense, and I totally agree. It's very important how to define the things. And also when it comes to social exclusion, that's we in GenPath, we only focused on one dimension. It's a multidimensional concept with exclusion from economy, from like poverty, or exclusion from access to health services, or exclusion from transportations, or exclusion from cultural participation. It's many things. In GenPath, we took only the social relation part, but then, one issue there is I think there are no gender differences in the feelings of loneliness, but the risk of experience loneliness is simply that it's higher in women. So yeah.
But there are intersections of not just women. It depends on.
Yeah.
I'm sorry, you need to take the mic, because otherwise people online see you, but they don't hear you.
No, I was just reacting to Maria's comments, and you're totally right, but I was just wanting to add that intersection sort of discussion, that when we talk about women, I always sort of think that, we need to be cautious, because women is very easy to generalize, and we're talking about, sections, categories, determinants, and there is privilege and there is vulnerability, and we need to make sure that we focus our priorities, at particular categories of women who really are living those situations of vulnerability, as it is in our section today about women and men living in vulnerability. And I was saying earlier also that we cannot really talk about vulnerable people, but we talk about the context of vulnerability that affects women and men and other genders differentially.
One final question from the room before we have a quick coffee break. Yes, well, sorry, the lady to my right raised her hand first, but if you have a pressing question, I'm sure you can ask our speakers over coffee. So, the lady to your right there, yes.
Thank you. I just wanted to ask to Karine, GenderARP, if you asked to LGBTQ people about their perceived risk of health, if they perceive that they have that they are at higher risk of general population from some risk factors. And if you asked also the barriers, about the barriers that they can face with when they approach with health services.
Yes, we talk about this aspect, about the it's interesting to see, for the barriers, for example, they really experiment a lot of barriers in the addiction services in general. In fact, they felt when we asked them, it's Maxime Blanchette, who is a doctoral student who really focus on the gay and bisexual men also, and they explained that for them it's a need of training, in fact, because when we ask specifically about what they need in treatment, they explain that they don't go in these addiction services because they feel they will not be understood or stigmatized, and they talk a lot about training because they see that for example, the clinicians are, well, they have good intention, but they feel they don't know about their sexual practices, for example. Their substance use is often really in the sexual practices and substance use, it's integrated in their mind and their experience, I should say, and they feel that they cannot talk about this topic when in general addiction services. So and when they go in the LGBTQ community services, it's really focused on biological risk. So they will have a good, for example, they have medical clinics where they will have some PrEP medication, for example, or they will have testing, HIV testing, but they feel that all these, the social aspect of their needs and the psychosocial aspect of their needs, the relational issues they live, how can the risk of being, for example, assaulted, there are a lot of victimization also in the men of these communities, and they feel that all the relational and social aspects of their experience cannot be addressed in these medical services. So there's a need to integrate medical services and social services, and to have also the transformation of services they are asking for is more training, more inclusion about their experience with their sexual orientation, so they can talk about all the importance of using substances. Also, it's important for their well-being. Maybe the last thing is that they feel that the only, like the goal that the professional wants for them is like abstinence. So, and also all the importance of integrate well-being in the intervention, and that sexuality and also sexualized substance use can be part of well-being, and it's not black and white abstinence. So there's a lot of systemic barriers and linked to stigmatization and lack of knowledge of professionals about their experience.
Thank you. Well, thank you all.